Hello, everyone. It's Nicola with Responders for Pride. I am here with Katie, our mental health ambassador, and we're going to go over the subject that nobody talks about today, and that is suicide. So it's kind of a question and answers. I'm going to ask some questions. Katie's going to answer them for us.
Yeah, and we'll just chat about it and have a dialogue. And I know that everybody watching has some kind of context around suicidality, whether you know someone who has experienced it, who has completed suicide, people just who have struggled with, if you've struggled with it yourself. So it's relevant. We're going to chat about it.
Sounds awesome.
Mm-hmm.
All right, so first question is, some people have that like suicidal ideation, and then some people just have those kind of thoughts about like, oh, I just don't want to be here right now. So how would those like active and like passive thoughts of suicide differ?
Yeah, so active suicide thoughts and passive suicide thoughts are different. They're actually distinctly different. They're two kind of experiences. But they do tend to get together. They tend to kind of travel together.
Gotcha.
But they are different. Active SI, which is like what we would say clinically, suicidal ideation, but we'll just say suicidal thoughts for our conversation today.
Okay.
Active SI is going to include specifically a plan to take your life.
Okay.
So a specific plan. And there's also going to probably be some intent there.
Okay.
Whereas passive SI or passive suicidal thoughts don't have a plan. There's no specific plan or intention to carry out that plan.
Okay.
And so it's a lot of types of thoughts that kind of challenge us wanting to exist or not.
Mm-hmm.
We might have fantasies of like not waking up in the morning, or getting like a terminal illness.
And that's like the passive.
Yes, that would be like passive thoughts, passive suicidal thoughts, where we're just really struggling with existing each day. And so we wind up having these like intrusive thoughts around what it would be like to not exist, to not carry these burdens.
Right.
And for a lot of people, it actually brings relief to kind of think about, okay, like there's a way that I could be relieved of this pain, of this suffering.
Right.
And a lot of people report that passive SI helps them to kind of say like, all right, if things get too bad, there's an escape route. And while that is a scary thing to think about, especially if it's your loved one who is suffering with SI or passive SI, it's something to consider when we think about how we might want to approach helping that person.
Okay.
When it comes to active SI, that's when we're, planning to try to take our life. And then that looks different in the sense of that would require like a full assessment. And one thing that I wanted to highlight was that I think first responders have a particular association with suicidality. I know that like my wife is in law enforcement, and so it's kind of a black and white thing when you assess as a first responder.
Absolutely.
Right?
Yeah.
It's like, are you going to hurt yourself or not?
Right.
And any kind of, inclination of that, okay, we're going to the hospital.
Yeah, I mean, we put everything under like suicidal ideation, whether it's passive or if you have a plan or not. So everything kind of goes under that.
Yeah,
SI.
and then you take them to the hospital.
Yes.
And that's where your job ends.
Yes.
And then the clinicians step in
Yep.
and they do that full assessment.
Right.
And so hopefully today we're going to be able to share and highlight like some of the nuances on the other side of it.
Okay.
So that first responders have a clearer like picture of, okay, well, what happens after that? Because it still doesn't mean that you're going to get admitted. It doesn't mean that you're going to be held. It doesn't mean you actually qualify. There are specific things that you have to boxes that you have to check in order for a hospital to hold you for evaluation.
Okay, so it's not guaranteed that 72-hour hold for these people. Okay.
No, it's not.
Yeah. So, I mean, then that's always like something that we think about is like they're going to be held for over 72 hours. So, yeah. So,
Exactly.
Okay.
Yeah.
All right. Oh, fantastic. So when it comes to first responders and like that suicidal thought, suicidal ideation, our police family, they have the lethal means at home with their service weapon. Obviously, we don't want to take away that pride. We don't want to remove their service weapon. But when they have those suicidal thoughts, what could we do for them or what could family members do for them?
Yeah, I'm really glad. I took some notes too because I wanted to make sure that I highlighted everything that I wanted to. When it comes to a first responder, and I'll kind of like flip between like just first responder and Leo for this part because any first responder can have a weapon. But when we are also talking about a service weapon, you know, I want to make sure and like highlight both of those things.
Sounds great.
And so I want to talk kind of directly to partners and family members.
Yeah.
Because we are the first responders to the first responders.
Yes.
We are the ones who see them when that front door shuts and that kind of role of whatever you do at work, you know, is out there, and then you come home.
And then the heaviness hits.
And then it all kind of hits, you're right. And so we're the first ones to notice some of these signs, and we want to be able to address that. And I know that it can still be scary because you're addressing it with someone who you love. There's a lot maybe at stake.
Right.
Maybe you've had kind of questions around it or conversations around it in the past, and it hasn't gone well.
Right.
So it might be like, oh, okay, I don't want to go there. But I'm going to encourage that family and partners especially, that you express your concerns clearly.
Yeah.
And that you take the lead in those conversations.
Which is hard because, you know, first responders have that type A and want to be in control all the time. Right?
Yes, but on this particular topic, a lot of the times a first responder is withdrawn and shut down and not wanting to verbalize, kind of wants to stop that conversation.
That makes sense.
Not always, but a lot of the time,
right?
right? It's like, you know, you get to maintain control of the situation if the conversation isn't had.
Very true.
So, so a lot of it kind of falls on us as loved ones to kind of step up and say, you know what, I've got some concerns. I've been noticing that you've been isolating more. You know, maybe you have been showering. You've been making these comments that scare me about dying and death. And so I need us to kind of come up with a plan. And I think one thing that we want to keep in mind is that we don't want to put pressure on the first responder or the Leo to kind of express all the thoughts and the feelings. That's probably too much.
It's not something we do.
It's overwhelming.
Yes.
It's not something you do. It feels wrong for a lot of reasons. So we want to kind of meet you where you're at, right? We want to meet our person where they're at and be able to say, all right, I'm noticing things are going on.
Okay.
And we don't have to talk about it right now, but we do need to come up with a plan to keep you safe when these things happen. And so kind of trying to engage in more of that, like we don't have to dive into the deep stuff right now, but I need us to have a plan that kind of helps, you know, lead the way for some specific planning around securing the weapon or any weapons in the house, so that moving forward, if there's a moment or a day where safety is not doesn't feel secure, then you guys can shift into that safety plan. Another thing that I do recommend is having like a code word or a phrase that will be easy to communicate, like, all right, it's a code blue day. Right. And you know what code blue means. And it's like, enough said, we don't have to go into any more detail.
Yeah. So I told my wife I'm operating at a 7. I'm like, I'm at a 7. And she's like, okay. Perfect. Like, because that's just, the anxiety is high for me. I'm feeling very stressed and overwhelmed. So I take that part, like, can relate very well to this. Like,
it works.
Yeah, it works.
It works.
It does.
A few words communicates a lot.
Yes.
Helps you feel like you're a part of that team. You're
Absolutely.
getting support without having to go to places that you are not able or ready to go to.
Right.
Vital for getting you through that.
Yes.
So, so coming up with some kind of code word, code phrase that you can use, and just be able to know, okay, so then what's the plan?
Right.
And so I do have some specific ideas for how to secure like a service weapon.
Okay.
and any weapons, but let's start with the service weapon.
Okay.
Let's kind of lean into that.
Lean into that one.
So I think in a lot of situations, maybe not all, but your Leo is going to have their service weapon probably with their gear, kind of in a central place in the house.
Mm-hmm.
It might be usually in their space,
Right.
kind of with all of their stuff.
Mm-hmm.
And so loved ones, spouses might kind of feel separated from the weapon, like that's theirs, I don't mess with that.
Right.
You might not even know the code to the safe. It
Right.
might just kind of be their territory.
Right.
Well, in this situation, that's where we're going to want to kind of explore, like, all right, how do we keep that your territory?
Right. Respects that.
That is your service weapon. It's like an extension of you.
Mm-hmm. Right.
But then also, how do we collaborate to make sure that in this situation where mental and emotional stability is not there right now?
Yeah, because at work, that's their safety line.
Right.
That's what protects them.
That's a great point.
Yeah.
Yeah, like that is safety in certain
Right.
contexts,
Yeah.
and it's danger in others.
Yes.
And so how do we differentiate that and respect that and be able to acknowledge it and say, okay, right now, this is actually a danger to me, as in the first responder being able to kind of
Right.
we want you to be a part of this process. The last thing that we want to be doing is treating our first responder like a child or like, give me,
Right.
This is not the goal. We don't want to shame them further
Right.
in feeling like they are not capable.
Makes sense.
So we want them to be, that's where we're going to have this collaborative discussion around, okay, how can we keep the weapon safe? How can you stay in charge of it,
Right.
but it can be neutralized?
Yeah.
So one way is to get like another safe,
Okay.
an additional safe for the house that is in your territory, the partner's territories,
Okay.
Somewhere
Like
else.
common ground.
Right.
Yeah.
Or like a particular closet
Mm-hmm.
where it's not just specifically, the Leo or the first responder's territory.
Okay.
That can be a key access only safe, potentially. And so it would be like, okay, it's a code blue night.
Mm-hmm.
All right, let's, grab your weapon.
Right.
Right. And the first responder is going to be the one to move that weapon from that safe to that safe. So it's like somebody else doesn't even have to touch the weapon.
Right.
You're still in charge.
You're still in control, still in charge.
Yeah. But but your loved one's gonna hold that key and just remove that risk.
Yeah.
Temporarily, so that you can move through this point of higher risk. If you have multiple weapons in the house, right, like a service weapon and other guns, and maybe you have multiple safes.
Which is common. I know a lot of people I work with go hunting and they have multiple weapons.
Right.
Yeah.
And you might have like one safe for your service weapon, you might have one safe for your recreational guns, or you might keep them all together. Nonetheless, you can go ahead and do the same thing, remove the batteries from that safe. Now it becomes key access only.
Mm-hmm.
Pretty much most safes have key access as a backup.
Okay.
And then code access for like normal. But if your batteries run out, right? If you die, you need the key to get in.
Yeah.
So you can just pull those batteries out, use what you have available. It neutralizes that. Again, you hold the key. Another thing that I wanted to highlight was, so gun safety locks.
Okay.
Probably, are you
I'm familiar?
familiar?
With,
yeah. It's like so they're like, it kind of looks like a zip tie, right? Like it's like a small thing that zip ties through the chamber.
Right.
And I know, I'm like, I know the parts of a gun.
Yeah.
But it zip so it zip ties through, I believe, the chamber.
Okay.
And it's a padlock, secure. And so the weapon can't be fully assembled. It neutralizes it completely. Can't be used. So this is another thing where if you don't want to mess with the safes or mess around with like changing safes or getting a new safe, that's something that can easily neutralize that weapon. It can be kept in the first responder's safe, in their space, like normal, but you're holding that key.
Right.
And this is something that I came across recently because I found out that Anne Arundel County here in Maryland, Anne Arundel County has a gun violence initiative of to reduce gun violence, and so right now, September 2023, they're offering 2 free gun safety locks.
That's fantastic.
To every household. You can go to any Anne Arundel County library. Don't bring your gun. Just bring, proof of residency. You don't have to have an ID. Just proof of residency. You have to be 18 or older.
Okay.
And you can get 2 free gun safety locks.
That's fantastic.
Yeah.
So other people could check your police departments and see if they have something similar that could actually help you out with that.
Yeah, that would be amazing if you could find it elsewhere as well for free. But yeah, that's a great resource, at least for us locally here, to be able to encourage. So it's like you don't have to spend extra money,
right?
And it's something that is effective, and it's going to help if you're really worried about your loved one or if you're worried about yourself.
Yeah.
This is a great tool to use.
That is a great tool.
Yeah.
Okay. Fantastic.
And then I just want to highlight, there are some of us who don't worry as much maybe about the service weapon, or don't worry only about a weapon.
Mm-hmm.
But maybe when your partner, your first responder, is, seemingly more unstable, they might, impulsively get in the car, and you're worried about, them taking some action on the road. And so, kind of same concept around collaborate with your first responder, talk about what are the things that make you less safe.
Right.
I notice that you get in the car, and I've been with you when you're upset, and it worries me how you drive.
Right.
And so, so part of it is we'll throw the keys in the safe too. We'll wait an hour. We'll wait a couple hours. We'll check back in. The whole point of this is not to punish.
Right.
Is not to, make you feel like you're not an autonomous adult. The idea is to help you feel safer.
Right.
And move through a temporary moment, because that's really what this is like SI, especially active SI, is a temporary moment that things become just too much.
Yeah, I think I read a study recently, because of the classes that I'm taking, is that normally that SI attempt that comes is made up in with that 10-minute mark. And it's like, okay, this is what I'm going to do. It's in that 10 minutes. And then after that, it's when you talk to them, you say, and they're like, it just came on, it was quick. And they feel a little bit of relief after when they're here. So it's like that first 10 minutes is very so. Yeah,
we're just trying to get you through moments that put your life at risk.
Yeah.
So that you can make another choice another day.
Yeah.
That's what we're doing. And ultimately, when we talk about these kinds of interventions, like the ones that don't include treatment or help, that's ultimately the primary goal, is keep you safe when you're the least safe, so that you can continue to move forward and see if you can make other decisions that will help improve your life incrementally over time.
Right.
And help reduce some of these symptoms over time.
Right.
Yeah.
It's good to know. So those people, they have those suicidal thoughts. They do not want to talk to anybody, right? They are not ready to talk to somebody. It's hard because we have such a stigma on it. It's such a dark place to go to. Are there steps that they can take when they're not ready to fully have this conversation or talk about it?
Absolutely. So SI, suicidal thoughts, is almost always about the desire to relieve suffering and not end your life.
Yep.
You want to end suffering usually.
Yeah.
And the pain, and it's when pain becomes too much and our coping strategies are not sufficient.
Never heard it put that way, and that makes so much sense.
Yeah. And so in those moments where that scale is just tipped too significantly, the pain is too much and the coping strategies are just not there, that can be an unbearable place to exist. And in those moments, ending our life seems like the only way to get relief, right? And so we can feel backed into a corner.
Absolutely.
Like, this is the only way that I'm going to be able to help myself. But reality-wise is that there are actually a lot of ways that you can help yourself if you're not ready to get help elsewhere. So I want you to consider that when you're experiencing SI
Mm-hmm.
of any kind, that it is actually a sign that something needs to be changed in your life. Not that your life needs to end, but that something is saying inside of you, we can't do this anymore. Something needs to change.
Yeah.
And so I highly recommend the anonymous hotlines and text lines. They are a great resource. It's something that you can use, again, anonymously, which
right.
means that you have that feeling of control, of autonomy. You get to decide kind of what you share. And even if it's just a couple of moments of
right.
a couple of comments or something, a couple of questions, just having someone
right.
that you can reach out to that doesn't know you.
I was about to say that doesn't know you,
doesn't know you, and that ideally you're not gonna feel judged by.
Right.
That's a great resource. I know that is for some people.
Right.
Like, I'm not there yet. That's fine. But I would say that if your SI is significant, that's one of your best resources.
Yeah.
Because again, going back to, we want to get you through this moment.
Right. And that's immediately talking to somebody.
Right.
So.
Yeah. And they can offer you some resources.
Right.
Also, again, if the SI is high, I highly recommend avoiding mind-altering substances. So if you can dramatically reduce or abstain, from alcohol, drugs, we all know that, and the research shows that there is a higher propensity for impulsivity, right? Lower inhibitions.
Absolutely.
And when you're suffering, a lot of the things that keep us from acting is that piece of us that's saying, this is permanent.
Right.
We can't come back from this.
Right.
And we do think about the consequences a bit more. When we're under the influence, we don't think about consequences.
Right. And we're adding a depressant on already a depressed type person.
Exactly.
Yeah.
So it increases the likelihood. More often than not, suicide attempts and completion is done under the influence of alcohol. And so that's something to consider is, just by not doing that can keep you safer. And then if your SI is kind of more moderate to mild, kind of like, all right, well then what do I do day to day? There are some strategies that I want to highlight. Journaling, I know it might sound cliche, but there is something about getting all this up here in the ether of your mind out through your hands onto a piece of paper or something. It is a processing technique.
Okay.
And when we get it out of ourselves, doesn't mean that we don't have those thoughts anymore necessarily, right? But when we get it into a different perspective where we're seeing it in words, in language,
a different process or a different thought on it.
Yeah, we're using a different part of our brain, and we're it can offer a little bit of relief internally of we're not just holding that all to our capacity, but it's it's out of us to some degree.
Okay.
And then we also have the ability to kind of look at that and reflect.
Yeah.
And say, all right, things are really hard right now. Right. And I'm not really sure how I'm going to get through it, but I can see a connection maybe between, a lot has happened this year.
Yeah. I feel like maybe journaling some of the good stuff too helps because you can look back and reflect on the good things also, maybe.
That can help.
That could help.
Yeah, because it can help us to, if we kind of dump all the crap out.
Right. Yeah.
all the terrible stuff, it can potentially make some space for remembering the things we're grateful for.
Right.
Remembering the things that do still bring us joy and fulfillment. It's oh, okay, but also, our brains have that tendency to kind of, but
all the time.
And so that's why we want to take kind of a paradoxical approach. It's if you're constantly trying to convince someone to be positive, what is their brain going to do?
Being negative.
Right. They're going to but blah, 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 blah.
Right.
So if you give yourself the space to write down all the things that kind of suck, it can potentially be trigger your ability to say, but I still do love me a big burger, you
Right.
know, burger and fries.
Yeah.
Maybe that's what you're living for.
Right.
That's okay.
Yeah.
Whatever works. Maybe that prompts you to go get yourself a meal
Right.
and treat yourself to something. So there's that potential to just open up some space when you get stuff out through writing or art, anything, just getting it
Through the hands.
Yeah, through the hands, or you could sing.
Yeah.
You know, it's kind of like that. It's what we would call like expressive art.
Yeah.
Bear with me, but yeah, it's a way of getting stuff out that doesn't have to be us verbally explaining it.
Yeah. I mean, for those of you that watch Grey's Anatomy, they do the dance, right? When they had a bad day,
yeah.
the dancing, they just put on some music, dance around in their underwear. So.
I've never watched Grey's Anatomy, but
Yeah, but that's it. Like that
perfect.
bad day, they just dance it out. Like so.
Exactly.
Yeah. So like
our body holds all of our stress,
Yeah.
and so doing anything like that can be helpful.
That's amazing.
Mm-hmm.
Yeah.
There are a ton of cognitive behavioral therapy skills
Mm-hmm.
that people can use to help themselves cope a bit better.
Okay.
These are kind of for more like immediate relief in terms of techniques like thought reframing or reality checking.
Okay.
So that might look like just kind of giving yourself a bit of a, hey, does what I'm feeling match what's going on outside of me?
Okay.
And that kind of can trigger, again, like, let me recognize that I actually have a lot to live for. There's like a lot in my life. I've succeeded a lot or I've achieved a lot.
Okay.
And so, yeah, I'm feeling like I have nothing,
Mm-hmm.
but the evidence doesn't suggest that. And so for our more kind of rational, logical, analytical
Beings.
people out
Yeah.
there, I'm one of them, that can be more appealing, of kind of giving yourself a reality check, cross-referencing how you're feeling to what's going on, and then being able to say it's not adding up. What's going on in here is not actually matching the situation. So then maybe I can just try and ride that out.
Is part of mindfulness part of that?
Yeah, mindfulness can be incorporated, and I
Okay.
would encourage it to be incorporated. It's a fantastic tool and technique for people to use. One thing when it comes to mindfulness, though, is that if you think that your symptoms are really directly related to severe trauma, mindfulness can be kind of tricky because mindfulness can actually potentially kick up, right? Some, being still and being present might be overwhelming when there's a lot of unprocessed, healed trauma. And so just be mindful of that. But one thing that I love to use, and I encourage people to kind of practice, try out, see if it works for you, is like the 5, 4, 3, 2, 1. I don't know if you've ever.
I do it all the time.
Okay.
Yeah.
Do you want to explain that since you're familiar?
So you kind of like you're overwhelmed, so you kind of look around and you 5 things that you can see. 4th. See, I always mess this up. So
you don't have to go in any particular order. Like you can.
Yeah, it's whatever you do. So I always do like 4 things I can hear, and then I do 4 things I can feel. Like, is it if I'm driving, do I feel the steering wheel? Do I feel the seat against me? Do I feel my shirt? Then I feel like my cup or something like that. 3 things I can hear, 2 things I can smell, 1 thing I can taste. So if I've got a coffee cup, I can drink my coffee and things like that. It just brings me back into what is going on right now. So that's mine.
Yeah, and that's a really nice mindfulness tool that can be less triggering because you're actually focusing your attention on these present moment things and experiences.
Yes.
Whereas, some mindfulness of like thought or feelings, that can be a bit overwhelming. And so the 5, 4, 3, 2, 1 is a great tool to use.
Yeah.
Like you said, cold cup,
Yep.
smooth,
Yes.
brown table, right? And you're just kind of labeling and describing.
The other
these
thing is the
things.
colors. Like I can pick a color and just focus on like green. Okay, so there's green in the flowers here. There's green on the map. There's green, and it just brings you back into what is going on right here.
And that's even simpler because you don't have to remember your senses or what order or anything like that. It can just be like, all right, red. What is red?
Right.
Red. All the red things.
Yeah.
And you can kind of pair that with just like getting yourself some deeper breathing and just can help make a moment a little bit more manageable. Give yourself some space again.
Yeah.
Yeah. So these CBT techniques are nice. If you're interested in trying them out, I do have some free resources on my website. You can kind of just download PDFs for like thought reframing or thought challenging, and just kind of for my clients sometimes they'll print them out and use them, maybe put them by their bedside, work on them before they go to bed if they get like flooded with thoughts before sleep. But then also a great way to remind yourself to use them is to kind of just like take a screenshot of the tool on your phone and like make it your lock screen or something like that, where it's going to come up
and you can see
right there over and over again. It's just going to remind you to use the skill or to try the skill, and it doesn't have to stay that way, but maybe for the week.
Right.
Yeah.
So when you're having that like code blue, it can be there, and it can be like your plan and your things that you need to do in order to get through.
Exactly.
Awesome.
Yeah. So, and so my website's katiebingner.com, and so if you go there, you can just, the very first page, you can scroll down and there's like a free tools tab, and it'll take you right to all the resources. I also have some guided mindfulness videos that you can link to there, and all kind of good stuff. So all free for you to use. And then honestly, I think just making a plan and taking it step by step. I know we've kind of heard of that saying of like one day at a time.
Right.
If you need to, take it 1 hour at a time. Maybe you plan to, it's like you might say, my SI is the worst at night when I'm alone after the shift or whatever, after your shift, whatever time of day that is.
And then there's that more isolation,
feeling alone, can't sleep, etc. So, if you're experiencing that, maybe you say, my plan is that I'm going to call one of my close loved ones and just talk to them. You don't even have to open up about this,
right? But
it could be a distraction from the internal experiences, and it can hopefully maybe even shift something around. You might feel cared for, you might feel connected after that call,
right?
And so those types of things, feeling cared for, feeling connected, are very helpful in reducing some of these internal experiences and making things a bit more manageable. Yeah.
Which is anxiety too sometimes.
It's usually a very layered onion.
Yeah, layered, like it's onions, right? Yeah,
or anything layered. Yes, it's we're complex creatures, and so when we get to the SI point, there's usually a ton of stuff under it that's just been stacking and it's gotten too high. Again, it becomes to that unbearable place.
And that's suffering, and
yeah. So even if we can just bring it down a little bit, it becomes more manageable. We can remember, we've been through hard stuff before, we can do this. This is still hard, but and just like setting yourself up. Another thing could be making a plan to say, I'm going to go for a run. When my SI kicks up, I have 5 steps. I'm going to, put my socks on, put my shoes on, take a swig of water, and put my headphones in, and I'm going to go for a run because my lethal means are at the house. I'm going to get out of the direct, space of that, and then I'm going to engage my body, which, shows that, engaging in exercise has the potential to shift our internal experiences, right? Like it can change our mood, it can help make space for other thoughts, and again, give us just like enough relief.
Changes the whole chemical thing going on in the brain.
Yeah, we've got a whole bunch of different chemicals pumping now, and so there's a potential for an internal shift in a safe space where you feel like you can maybe even feel proud that, okay, I did something productive for myself.
Right.
Yeah.
That's good. So we work in a place where we see suicide attempts, we see suicide thoughts a lot. We are at when helping hurts us. So when a colleague makes a joking or a statement about suicide, our response is, and back out of the room, right? Because it's scary to talk about. So it's so scary to talk about. Yeah. How do we help them?
Yeah, it's scary for clinicians. We're trained thoroughly, most of us, in handling that stuff, and it still does the same thing to us even seasoned professionals, that automatic stress response of there is a potential crisis about to happen in front of me or around me or near, and that's an understandable response.
Yeah.
And so, honestly, the first thing I would have you do is take a pause and see if you can just breathe a little bit and calm yourself down. Because you're going to be the most useful and helpful to that person who is being really brave and courageous in opening up to you when you are more grounded yourself, feeling more capable to be a listener, rather than in that, stress response mode. Right. If they notice that you're freaking out, they're going to turtle, right? They're going to go back into that shell, and it's not that... it's understandable to have that reaction. And so if that's happened before, go easy on yourself. Let yourself slide. You're doing your best. But, see if you can remember that the first thing you can do is actually take care of yourself in that moment. Just take a pause, do some breathing. Yeah. You don't have to say anything yet. If you just need to focus on kind of calming yourself down, that's going to be one of the best things to first do. And then I would say, in that time, as you calm yourself down, see if you can do a little bit of internal shifting. Okay. By that I mean, can you recognize that the person in front of you is being very vulnerable?
Because that is vulnerable. They're in a very dark place, and to just say that.
To be willing to consider that they would open up to someone and potentially get some help, right? That's a scary place for them to be. Takes a lot of courage. It's also a positive thing. It's a good thing. It's a good sign. It's when they're not talking to us. It's when they're shutting everybody out. That's when I start to get really concerned. But when someone's coming to me or coming to you and saying, whatever it sounds like, right? Recognize this is good. This is a good thing in the sense that they are trusting me. They're opening up to me. They're taking an opportunity to help themselves and actually maybe get some help. So this is good.
Yeah. Okay. Right, because we would think the opposite, like, oh, crap. This is not good. I'm going to just slide away from this conversation.
Yeah, it's scary. It feels bad. And, we want it to stop. Yeah. And one of the easiest ways to make it stop is to not continue that conversation. But unfortunately, that does then leave higher risk than on the table.
Yeah, and we were talking about earlier, but I think that stigma of if we talk about it, we're gonna give them that thought process, right?
Yeah, that's a myth.
Right.
That's been debunked, and so talking about suicide, asking about suicide, that does not put the idea in anyone's head. It does not encourage anyone any more than they already were feeling it. It does not. In fact, what research shows is that it lets some air out of the balloon for them. That pressure that's built up inside of them to hold all of this burden on themselves and not let anyone else know or think about it. Yeah.
So that's good. So if they've come to you and said something that's positive, and then us being able to then talk about it and not go away from it is actually more helpful.
Yeah, remember, someone talking about suicide does not equal automatically imminent danger. Right. Does not mean that they're automatically in danger of attempting. And so we want to try and find that space to lean into and say, okay, they're coming to me. This is good. They trust me. That's good. So I have an opportunity here to learn more. And that's what I would want you to do next, is get curious. Okay. And so the idea here is to ask sincere follow-up questions when it's time. Maybe you listen for a while. Oh no, I skipped a couple steps. I want to go back. Yeah, because I want you to reassure them. Okay. So before you start asking questions, you might be getting curious inside. Right. But reassuring them. I'm so glad that you're talking to me about this. I'm happy that you came to me and that you feel like you can trust me and I want to help. Right? So just reassuring them that you are there. You want to use some of those active listening skills. One of the reasons I love talking about this is because I'm also a communication coach. Okay. And this this is like highlighting some really meaningful communication skills.
Also, us as first responders have a writing reflex, right? So we want to make everything better. That is our job.
The fixers.
The fixers. We're the fixers in life. So, like, being able to stop and actively listen is, we just want the details quick so I can fix you, right? Like, to actually listen to everything else can sometimes be hard for us. So this will probably take a little bit of work for some of us, I think.
Hey, I can relate. A lot of us therapists are that. This is one of the earliest tattoos, and it says "just listen," because I had to remind myself
To just yeah.
You're going to get a lot more helpful information by listening to someone than by trying to convince them of something or to do something or not do something. You want to meet them where they're at. You have to listen in order to do that.
Right.
So here you might not use so many verbal skills, but your nonverbal skills. So you might lean in.
Right. So.
Right. No. Yeah. Open posture.
Right.
Use your facial expressions to express, like, I'm hearing you nodding. Like, let them know you are there. You are present. And that you are attuned. You're hearing what they're saying. You're hearing what they're saying. That they are struggling.
Right.
That this is hard. And that they're scared.
Yeah.
And that you get it. So we want to lean into that space before we start asking questions. Okay?
Yep.
But if you're able to get to that point and you're feeling like that's going well, and that person who is finally opening up to you, to someone, is receiving that from you,
right,
then we want to start asking some sincere follow-up questions. Things like, what has this been like for you to carry this all this time by yourself?
Like the open-ended questions.
Absolutely, yeah. You might also ask, how long have you been feeling this way? How long have you been having these types of thoughts?
Right.
Does it come and go? Kind of thing. You're genuinely curious. You want to understand, like, what's going on for them with this, right? You also can ask things about, like, other stressors in their life. A lot of times, SI is a result of cumulative stress. It's different areas of our lives that have become unmanageable. There is no space of respite.
Right. And for first responders, it's the suicide level rate is much higher for us.
Yep.
Right? Because we have all of that secondary stress.
Yep.
So, and then there's family stress, and then there's financial stress, and then there's friend. It definitely can be a lot. So yeah.
All of it piled up.
So it's normally not just one thing that all of a sudden came about.
Yeah, you're absolutely right, and I'm glad you highlighted that, because I think it's really important just in normalizing this conversation of, like, SI. So just to put it in perspective, the average person who doesn't have clinical depression or would maybe qualify for a diagnosis, the average person thinks about their own death a handful of times a year.
Okay.
That's just something that as humans we have thoughts about. And it might just be like a thought that comes in and then it goes.
Right.
But then when we start experiencing trauma-related injuries, and when I say injury, I don't just mean physical, I mean mental and emotional, all of that, experiencing a trauma affects us on every level. When we start developing depression, severe anxiety, all of those markers then wind up increasing the likelihood of especially passive SI symptoms. And so as we consider, our likelihood gets higher and higher the more that we experience these struggles. So it makes sense that you might be having them on a regular basis. But that being said, it is still a significant symptom. Right. And so we want to be able to recognize that it's a sign that things have become or are becoming too unmanageable. We want to catch that, and we want to do something about it before it gets to a point where you feel like it's unbearable and not manageable anymore. And so getting back to that specifically of, like, what to say. Ask if you feel like, if your gut is telling you that something might be going on here in terms of suicidality, ask the question.
And we normally have a pretty good gut instinct.
Yeah,
right.
You do. And so you are able to read people, especially people you work with, fairly well, right? You know them.
We spend a lot of time together.
That is an intimate, I don't mean sexually, but that is an intimate profession. Any kind of first responder, like, you feel like you're in that that group that gets it,
Mm-hmm.
and the camaraderie that's there is a very intimate thing.
Absolutely.
And so you can pick up on stuff without people saying anything.
Right.
And so what you want to do is directly and compassionately ask the question, have you been thinking about killing yourself?
Now, do you word it like that? Because I know that, again, that's shying away, right? So, is, you know.
So you can.
Okay.
But there's also the option of, you know, do things ever get bad enough to where you feel like you want to end your life?
Okay.
You want to be direct. You do want to be clear. You're asking about suicidality.
Right.
But there are ways to do it, right? There's nuance in that communication.
Mm-hmm.
But what you want to make sure is that it's coming out in a caring way, that you're not just like grilling them. You're not, you're not freaking out and needing them to calm you down by saying no.
Right.
That's not what we don't want to set it up.
Right.
We want it to come out in a caring way where we're genuinely asking, are you having experiences of like wanting to die, or thoughts of wanting to die, urges to want to, like, what's going on there? Is there anything going on there?
Right.
And let it be okay for them to answer however they need to answer.
You have to give them that space.
Yeah.
Yeah.
Because they, honestly, that's going to be in their court now.
Right.
To answer. And I answer honestly. And you can't control that. But what you can do is set it up to be a safe space. That if they're not ready to say it now, maybe they will call you later and say, I wasn't totally honest. Or maybe in a week they'll come back to you and say, things haven't gotten better. And yeah, like they're tipping that way now.
Yeah.
And that is a huge ability to open a door and actually make somebody a lot safer, potentially.
Yeah. Because even with you asking that question and they don't want to answer it right now, they're giving you the chance to be able to do that later. Yeah. Right? You've opened up that door for them, which is...
That's exactly right.
Yeah.
And so what you don't want to do, if somebody does acknowledge, yeah, I've had those thoughts, or yeah, I've had a lot of those thoughts recently, or yeah, I am kind of going that direction. Mm-hmm. Whatever it might be, if it's kind of a confirmation of, SI's going on, then what we don't want to do is express judgment.
Right.
We don't want to use guilt or shame, which is a common way. Again, it's a common stress response for us to want to shut it down by saying, like, you're not thinking about doing anything stupid, are you?
Right. Right.
Or like you can't do that to so and so. Like that would be so selfish.
Right.
You know, like you're not a selfish person, or don't be selfish.
Right. They're already feeling those things, right?
They're already feeling so much shame.
Yeah.
So much guilt. Mm-hmm. They're already feeling so much self-judgment.
Right.
That is a part of why they're experiencing this elevated suicidal thought symptom.
Yeah.
Don't add to it.
And then you went from somebody they can trust to somebody that just shut them down.
Don't add to it.
Right.
Resist that. Notice that you're panicking.
Right.
Because that's what that is. That's a panic response, right? Mm-hmm. That's tell me you're okay so we can move on and I don't have to feel freaked out anymore.
Right.
That's understandable to feel that. Don't act on that. Okay?
Yes.
Do your best. Instead, let them know you understand. Let them know you care.
Okay.
Let them know that you are open to trying to help them in whatever way that you can. That you're, again, like you said, that safe person.
Right.
That they can come to and talk about it. That also means, keeping it open in terms of letting them have some autonomy in this conversation. Are you okay with continuing to talk about it?
Right.
Do you want to come back later and like revisit this topic? Or, I know that it can be scary to think about letting it go.
Right.
But there's a big piece about autonomy, and then we'll talk about that in a little bit, but there's a big piece about autonomy here that actually reduces risk. So that's something to keep in mind, is that we each still have that. You want to give this person that opportunity to talk as much or as little about this as they're ready to.
Yeah. Mm-hmm. Like you can't put that pressure on somebody. Like it just
that doesn't work. Doesn't help. So if somebody, I want to get like really into it now. If somebody expresses SI to you directly, like I'm not thinking about being around come later this year.
Right.
might just be dead.
Oh.
Yeah, right?
Again, that's that.
Whoa!
Right.
Whoa! So, again, stay calm.
Yep. Which is hard, because now you're just, right?
Oh, yeah. It's not easy, but we want to try and remind. That's why we're talking about this today.
Maybe take that pause, look around for some colors. I don't know. Like
a drink. But do something that gives you a pause that says, wait, okay, freaking out does not help here.
Right.
And if you are able to get curious, start asking some more questions.
Okay.
Not in an interrogative. Is that the word?
Yeah, kind of.
Don't interrogate them.
Yeah.
But instead, like, how often do you have these kinds of thoughts? Like, how often is this like an everyday thing, or
right?
Or you might ask,
because you said before, like the normal person, a handful of times a year, so that's normal. So, but them to have it a few times a day, a few times a week is scary.
These details are
high
gonna
risk.
Yeah, they're gonna tell you like where this person is actually at in their symptom, and so it's like, okay, so maybe they're like, I don't know, like it pops up every Monday when I have to get ready for my new shift or something.
Right.
So it's like, okay, so that's good to know. So then you might ask like, well, what do you do when it gets like really bad? Like, what have you done in the past to like help yourself through it?
Yeah.
Get curious about how they cope.
Right.
Maybe they're like down, a couple shots, and it's like, oh, okay, that's high risk. Okay. Like mental note. Oh,
right.
Okay, so that's giving me more information that this person might need extra support and help right now.
Right now.
More like immediate help.
Yeah.
Maybe they say like, I don't know, I just go to sleep and kind of hope that I don't wake up, and when I wake up, sometimes I feel a little bit better, sometimes I don't. And you're like, okay, well, I get that. You're giving yourself kind of like a delay. Like, I'm just going to go to sleep and hope for the best when I wake up.
Right.
You can ask them if the thoughts scare them. They might not.
Right.
They might say, no, I kind of feel a little bit better when I think about it. And that might jar you.
Right.
But again, keep in mind what we were talking about before.
Right.
Having the potential escape route from the unbearable pain
could feel better.
Can actually buy them a day.
Right.
Or a week.
Yeah.
So while we don't want them to be staying in that state all the time of just buying time, that's an essential resource when things are really bad.
Right.
So, okay, yeah, that makes sense. Like, I'm glad that you're able to give yourself a little bit of relief just by thinking about, like, not having to carry all of this pain and hurt and burden all the time. I wish you wouldn't have to carry it either. Like, I get that.
Yeah.
Relate to it. You could ask them, like, what they might need to feel safer. If that feels like a good question to ask in that moment. Like, well, how do you keep yourself safe, or what do you feel like would help you feel safe when that kicks up?
Yeah.
And just see what they're willing to talk about or open up about. But it's going to give you some information about kind of how immediate the situation is, and if you need to act sooner rather than later, you can start kind of offering specific resources in terms of like, well, there are some amazing like first responder informed providers out there that can really help you with this. Right. Because we don't want to send I do not want to send a first responder to anybody who is not first responder informed. Right. I would, it would be heartbreaking for someone to build the courage to finally go and get help. Yes. To then be met with, a good intentioned but underinformed provider who then makes things potentially worse. Right. And then the likelihood that first responder is ever going to go back to get help is very low. Very much. So we don't want to do that. We want to set it up so that's when you might say like, have you ever heard of like the Code Green campaign? Right. Or I get therapy here. Right. Or there's this one place not too far from here that is like it's like run by first responders, and so they get it. And we have 2 in our area in Maryland, and there's multiple different links, and we have the resources on our page also. Under our resources tab, we'll link that too. Yeah. But there's many first responder resources out there for
people anonymously to talk to too if they need to. Yeah,
exactly. Anonymously, tons of resources. And then, like you were saying, in Maryland, there's actually like quite a number of first responder informed, like brick and mortar or teletherapy providers here.
Yeah.
And it is important that we highlight here because each state has different licensure, so we can really only speak to, like, you know, if you're here in Maryland, you can seek providers that are licensed in Maryland. Right. Now, they might be in Hawaii, but as long as they're licensed in Maryland, they can provide you therapy.
Yeah.
But we want you to be going to someone who has at least enough understanding about this career and the experiences that come with it, so that they don't make any of the kind of dumb mistakes that us well-meaning civilians can make.
Yeah, I mean, I think also the offloading of our first, like, I do not try to talk to my wife about the calls that I see, right? Because I don't want to put that burden on her, right? So I talk to somebody that is not first responder or a veteran or that doesn't understand the things that we see, and I start talking about it, and then I see this look of horrific come across your face, and we're like, this isn't the person to talk to. Right.
Yeah, shut down,
right? Because
you're not going to get it.
Burden of the things that we have seen, not including all the other stresses we have in our life, but just the things that we've seen, to talk about those and offload those is sometimes hard because we don't want to put that burden on people.
It's exactly it. Like, that's one of those barriers. Is, you know, if you can't bring your authentic experience and self to treatment, then and you feel like you have to take care of the provider, or that you have to, like, teach them about, no, that's not your job. Right.
And that's what will happen is we'll see this book and we'll be like, wow, right? And then there's always the dark humor that we then take into it, and then we shut down.
Right.
Yeah,
exactly. So finding the right fit is going to be huge, and that's something that you can offer someone who seems like they're in higher risk situations, is that, like, hey, you know, the most successful athletes seek mental health, the most you know, the toughest veterans that we know in our lives seek mental health. You know, mental health is not just for mental illness, it is for addressing human struggles. It's just there for us to help us move through times in our lives, situations that are just too much, and make it more manageable. And it's in that objective space that, if you find the right fit, is invaluable. It really makes all the difference.
Yeah, absolutely. Yeah.
And so, kind of some final thoughts in terms of this conversation that you're having with someone. You do want them to, you want to follow their lead. Okay?
Yeah.
We're not trying to pressure someone to go get in the car with us and go to the hospital. Okay? You want to acknowledge this is extremely hard to talk about. This is a hard thing to even consider getting help about. I want to come back to that personal autonomy piece. Because personal autonomy around our right to live or die is a significant piece of, like, the trauma-informed approach to suicide risk and reduction. It seems counterintuitive. Our instinct, even as other first responders, the instinct, fix it, solve it, get them safe, make them safe. I'm a saver. I'm going to save you. In this moment. However, interestingly enough, the research shows that when you push against someone's autonomy to live or die by suicide, it has a potential to trigger a reactivity and, like, oppositional resistance. And can actually then push them more toward suicidal behavior rather than away from it. So that's something to consider, is that people want to feel in control of their lives. We all do, actually. It's a fair thing to want.
Absolutely.
And in this situation, they're considering their option for suicide might feel like the only thing they can control. So we don't want to completely remove a sense of control. We have research that also shows that when someone is forced to get help, there is a higher risk of suicidal attempt after hospitalization. Because people, if they're forced and they know that they are going to lose all control, they'll kind of hold on. They'll just hold on. They'll get out of the hospital, and that will, because they've been activated. They've been, activated. And they've been taught that in that moment that everything is unsafe. And so we want to try and reduce that potential as much as possible and really make it a collaborative effort.
And that's where that active listening, going back to that, comes back in. And,
we want to make it a collaborative effort. Most people have to work their way up to getting help. And getting help in and of itself can be really scary.
Yeah.
Right?
Even if you're not suicidal. Right?
Oh, yeah.
Just like in general.
Less than 40% of the general population seeks help, seeks mental health help. So consider that's the general population, less than 40%. So think about what that means for then the first responder community, which our stats are really poor on that because, again, how do you get accurate stats when people don't report? Right. And also there's not a lot of questions being asked, but now there are more than ever. You know, there is more research into first responder mental health. But it's still being underreported. So you can't fully have but we're going to estimate that it's a significantly lower number even than that.
Well, because there's such a stigma
there is.
Leave your feelings at the door.
Yeah.
Okay, this is what you signed up for.
Yeah.
Right? And it's, yes, I signed up to help people, and I knew I was going to see the things that I was going to see. I did not sign up for the way that I was going to process and affect them because they're different, right? So that whole process is that stigma is very hard. So the fact that they're wanting to get help for suicide is like next level steps, right? Like, huge.
Yeah, you're right. I also came across in some of the research that I was doing that stigma isn't the only thing that really stands in the way. A lot of it also has to do with lack of knowledge, just like basic information about mental health and mental health care. For whatever reasons, first responders aren't getting exposed to a ton of information
I would say
then debunks the stigma.
Even in paramedic education, right, our behavioral health is not large, right? We don't learn like trauma-informed care. We don't learn behavioral assessment. Those things aren't part of, right? So if we were teaching those to our
crisis intervention, right?
So if we were teaching those to our EMTs and things within class that will help our patients, imagine what it could do for the provider also, right? So
exactly,
so that knowledge not being there is like twofold, right?
It's twofold because it allows the stigma, I think, to continue to exist strongly.
Absolutely.
It defaults you to, well, I guess I just have to pull myself up and keep moving and get harder and harder, and we compartmentalize more and more deeply, and that makes the build-up more significant.
Yes. Yeah.
So there's that twofold piece of education, which is why we're having this conversation today. I'm hoping that everyone's going to walk away feeling a little bit more aware of just like suicidality and how to address it and how to take care of yourself and how to notice it and what it is and what it isn't. And I also wanted to highlight some other stuff about that piece.
Okay.
Like about people being afraid to, if they are, let's say you're in treatment. Okay. Let's say you're getting therapy.
Yeah.
And you're having suicidal thoughts, but you're afraid to mention it. Because I will say, in my experience as a clinician, almost 9 years now, 100% of people, and mostly not first responders, just general people, 100% of them, when I wind up bringing this topic up and opening up the dialogue around it, they wind up telling me, oh yeah, no, like I'm not going to say anything, or I wasn't going to say anything because like I don't need to be going to the hospital. Like I don't want to go to the hospital.
Well, and again, like I said in the beginning, you mentioned, I feel like I don't want to be here, right? There's not that thought process. There's not a plan. There's not a lethal means. Nothing is there. We're like 72 hours.
100%.
It's
the reactivity. And it's also a part of that, you talk about like, that fixer mode, right? It's like, this is something I can do.
Right.
This is the right thing to do. Well, and for some clinicians, like, this is how we're trained too, is to immediately kind of go into a reactive state. And that's why we do want a trauma-informed provider. Usually a first responder-informed provider is going to be, hopefully, a trauma-informed provider. And so, being able to know, I want you to know, like, your rights going into treatment around this topic. And so, recognizing that pretty much everybody's afraid of being hospitalized, and that's why they don't talk about SI.
Yeah.
And so, just off the bat, I think we highlighted before, having suicidal thoughts does not automatically qualify you for hospitalization. you're used to, maybe as a first responder, reacting to any of it, and then you bring them to a clinician, and the clinician does their job. So let's fast forward through that process and say, okay, you're at your therapist's office.
Okay.
You're already with a clinician.
Okay.
Okay? So you didn't need to be brought there. You brought yourself there.
Okay.
Now you're having this conversation. We are bound by HIPAA laws.
Okay.
I think most first responders are probably familiar with HIPAA. It's
Very familiar.
National law around confidentiality. Mental health confidentiality is stricter than general health care. So we are really bound by making sure that if we're going to breach confidentiality, and there are reasons that we have to, one is being an imminent danger to yourself or others,
right?
We better assess pretty thoroughly for active SI, for passive SI, for history, for all of that. We better get a real nuanced perspective on this person and the condition they're in right now with us, because that's all we have to go on.
Right.
That's what we are assessing, is are they a risk right now? And so being able to know that you can go into your therapist's office and say, I need to talk about these intrusive thoughts that I've been having. I keep having this intrusive thought of driving my car into this one particular tree on the way to work.
Right.
And I need to be able to talk about that without you panicking, without you causing me to panic. Like,
right.
I need us to talk about this.
Yeah.
Because I want you to know, and it's important to be honest, obviously. But if there's no intention there, you're just really distressed by these thoughts.
Right.
They keep showing up, or maybe they're getting worse. This is the place to work that out. Sending you to the hospital isn't necessarily the appropriate approach unless you say, I'm going to leave here and I'm going to go do that.
Right.
And
Because
so,
they're sitting in a room, right? And they're not maybe talking through it, maybe. Like, unless they get their initial assessment done, right? It's just 72 hours. I mean, in a lot of the hospitals, they've got a sitter outside the room. And that's about,
Yeah.
And then the clinician comes in when they can.
Yeah.
Right.
It's just preventing action.
Action, correct.
And so we have this opportunity when we're in treatment, whatever level of treatment you're in, we have this opportunity to prevent needing to go to the hospital, to actually address the issue. This is the setting we do this in. This is where we do treatment, right? This is where we address the issues. And so knowing that you can self-advocate, knowing that you should be a collaborative member of this process, your clinician will likely want to do some safety planning with you at the very least. Well, okay, consider how do you want to participate in the safety planning portion?
Right.
What is that going to look like? The idea here is to keep you out of the hospital, is to address these thoughts, these symptoms, so that they can start to come down.
Yeah.
And knowing how you're willing to participate, and knowing that you need to be a willing participant in that process.
And that comes back to the patient autonomy. Right, being willing and wanting to do these things.
Exactly.
Yeah.
So I want you to be able to know that you can go into treatment and recognize that as your provider, not only do most of us really want to maintain your confidentiality, but we're bound by that law. And so we're going to be making a nuanced decision based on the person in front of us and how much we know them. Right?
Yeah.
Because I've worked with people who have, people who experience, for example, mood disorders, years of suicidal ideation up and down. Yeah. It's a common part. Sometimes it's so common that they wind up not even noticing that it's kicking up that much, because it's oh, there's that again.
Right.
Again, it's a significant symptom. We want to be addressing it. But for a lot of people, it comes and goes.
Yeah.
And so we want to be able to recognize that doesn't mean you're going to go to the hospital every time it comes and goes. We want to treat. We want to adjust things. We want to figure out, are you utilizing medication? Does that need to be adjusted?
Right.
What's your self-care routine looking like? Just talking through. Did you have another really bad call this week? Or is that one bad call really coming up? Or are those 10 bad calls all just caving in on you again?
Right.
And so this is where we do the work. This is that space. And I really do want to encourage people to try and see if they can feel like they can tap into their right to use treatment in that way, and really be able to address these issues in that setting so that we can avoid that thing that everybody's terrified of at all costs.
Yeah, and it's that you being that safe space.
Yeah.
Right, and being able to talk about it openly.
Yeah.
Right, because I mean, you do this for a living, right? Also, so there's no judgment from like family members or things like that. Like, should be able to come to you and it be very open.
Yeah.
So, I think being able to talk about that definitely helps each person with being able to self-advocate for themselves, I would say, right? And to be able to move that story forward, right? Move that thought process forward.
Yeah. It's either going to accumulate or it's going to start to dissipate.
Yeah.
And what we do and how we handle it plays into how it's going to go.
Yeah.
And so empowering people as much as possible to know that you don't have to keep carrying this burden, and with every day the potential of more burden being added, especially as a first responder, you are going to experience cumulative stress. You're probably going to experience cumulative trauma. So we want to recognize that that's going to put you at higher risk for these types of symptoms and put something in place so that when it comes up, you got a plan. We know what to do. We know how to help it peak lower and stabilize you longer term.
Okay. Is there a point where you would get to an emergency petition with a person? Like, is that when the actual like plan and thoughts and
there's two ways that goes.
Okay.
And I've had both experiences. And so either it's this person comes and says, I am not safe and I think I need to go to the hospital just to make sure that I get safe and stable. That's what hospitalization is for. It is for stability and safety, and that's it, really. And so there's that scenario, which is always the easier one, obviously, because it's a cooperative, collaborative approach. And then there's the instance where, you have to do an emergency petition because there's understandably a lot of resistance for a lot of reasons to going. But you know that this person is in danger and you can't keep them safe when they leave your office. Right. You know, know that they're in danger and you can't go with them and you can't keep them safe. So that's when an emergency petition would come into play. Yeah, it's rare, but it can happen.
So I think a lot of us first responders feel like it can affect us with our job and things like that. So that's awfully one of the other reasons we kind of want to stay away from
100%.
Even talking about it.
Exactly.
Right.
So and that's why we kind of go back to that conversation around like, so do what you can and use the resources you have. And if you're never fully comfortable talking about it, okay. But if you're using resources, if you're getting some help, even if you're getting therapy and you're not talking about the SI, you're getting help in other things. Again, SI is a result of all that buildup. So if it's still there, hanging out at the top, but you can start dismantling some of that scaffolding that's getting you to there. It's always going to be there. One of the analogies that I use with my clients to talk about SI more freely so we have more open dialogue when it's coming up is like, where is it on the shelf? Okay. You know, we've got lots of resources on the shelf. Yeah. How high up or low down is SI today? Okay. You know, are the suicidal thoughts like right in reach? Are they on the top shelf? You see them. Right. It's a little comforting to know they're up there. Right. Just in case you need escape route. Yeah. But they're not close. Okay. And you're not tempted to reach for them. Yeah. You know, and so that gives a bit of a safer language sometimes. Okay. To kind of describe where we're at with that symptom. But again, even if you're not ready to talk about that openly, you can still be getting a ton of help and resources that help ultimately manage that symptom over time. Yeah.
Okay. Yeah. So it's like everything's on a scale, right? Like everything's on a scale. Yeah. So I know that in my department, and my county, we have a crisis team that we can have come out for certain things and things like that. But what other ways can departments kind of help us address like our mental health needs, like the things that our department should be doing instead of causing the stigma? Making it open.
Yeah, this is so important because it really should not be only down to the individual to push against all that,
Right.
you know, to kind of go against the grain and say, I'm going to be the one that's going to talk about this, or I'm going to be the one that gets help. So it really should be this thing that we're institutionalizing in the system,
Absolutely.
that this is normal.
Yeah, absolutely.
And we build it in. And so some of the things you can do, so the CISDs, the critical incident stress debriefings, those are good. I think you guys do them.
So
Or
yeah,
try
I
to
do,
some
like,
kind
so
of
we always
capacity.
do just a talk after. It
Yeah.
might be a day after, it might be right after, but we just kind of talk about, and not even just what we are feeling, just what do you think went well in the call? What did
Yeah,
you see that was
processing
different from
the
me?
experience.
Just processing some of it. And then we do have critical incident stress if we need it.
Got it. Yeah.
Is an option that we can bring in for, so our CISM team, critical incident stress management, is, they are not deployed every time we have a pediatric cardiac arrest. They are notified when we have a pediatric cardiac arrest. So
Yeah.
yeah,
That's definitely a call that they need to be informed about. But so there's the official CISM,
yes,
and then there's the kind of more casual
I
conversations.
do the casual conversations with
They're
my
all
peers.
important.
Yeah.
And honestly, I think that they both of them play a really significant role, because research is showing that some first responders are triggered by the kind of the debriefing that's too intense, which is understandable.
They are
It
intense.
can go either
Yeah.
way, and so you want to be able to like let it be that flexible resource where no matter what, there's going to be something offered to help them process what they just experienced
Right.
to some degree.
Yeah.
Again, letting the air out of the balloon a little bit, that can make all the difference. Peer-to-peer support programs are finding some success. I know Anne Arundel County has one that they've been building up for years. It is a kind of a volunteer, peer, trusted based program, and it offers like check-ins. They touch base. So like a particular group of officers, this is the police department, officers, will volunteer to do check-ins after particular calls, but also check in about like, hey, I know you've been going through a lot, or maybe, a colleague is getting divorced, or maybe they're going through like a grief, loss of someone in the family or something, and they just need that touch base.
Yeah.
Know that the people around them care not just about like,
And again, we're an intimate group, so a lot of us do know what's going
Yeah.
on everywhere. So like being able to have that
right, and
dialogue together.
and you're not meant to be a mental health
Right.
provider. You're just kind of that liaison, or that bridge of like, I want to check in, I want to see how you're doing, I've got resources,
Right.
do you need anything? Just that care, just knowing that you're there can be such a relief
Right.
to so many first responders, knowing that they have a department, or they're at a station where they are feeling like if something gets bad enough, I've got that support.
Yeah. And not the generic check-ins.
Right.
Right? Because I think that we know the difference between the people that will text us and be like, oh, I heard you had a bad call, you okay? Right? Like you get a lot of those texts, and then it's the ones that are the genuine, what do you need? Right? Like instead of being like, oh, I hope you're okay, let me know if you need anything, the question of what do you need is, I think, a lot different too.
Yeah.
Yeah.
Even just offering out and saying, hey, we're going to be off at the same time on Thursday. Let's hang out. Let's chat.
Yeah.
Like, I just want to touch base with you.
Yeah.
Taking that step to be able to say, because again, we know how hard it is to just receive help, let alone ask for any.
But absolutely not going to happen, right?
Right.
Yeah.
So we really want to make it as a smooth as possible kind of process of again, the peer-to-peer support program is, we go to you.
Yeah.
Right. We come to you, we check in on you, we ask some of those open-ended questions. We offer that support and those referrals. You're not alone.
Right. Yeah.
So even if you just like need us to hang out.
Yeah. And it's okay to not be okay.
Oh, always. Right.
Like when the question is, are you okay? When you say no, people are like, I don't know how to handle that. So this is the peer-to-peer is a nice thing to be like, when you say no, they're like, okay, then let's do this.
Exactly.
Yeah.
It's a genuine, authentic question.
Right.
And they're there for it, whatever answer you have.
Right. Yeah.
Also, having a flexible return to work policy. You're
Yeah.
laughing.
I laugh at that. I do.
What's funny?
So I think that a lot of especially the EMS personnel who see constant, right? We fight for mental health days all the time, right? So, or we have, and again, it's like, how do you determine what is traumatic for somebody, right? But when you have a certain call that really is a one-of-a-kind call, and it has affected multiple people, I don't think we should be going straight back to work.
Right.
I feel like you should get a couple days, right? And I don't think you should use your sick times for those couple days. But I probably would gather to say 98% of departments make you use your sick time for those days. And you've just seen the worst in humanity. I'm not talking like the little old lady that fell and broke her hip. Yes, that can be triggering to some people, right? Like,
no, but
it can bring you, but like horror, right? So yeah, I do laugh at that because again, 98% are just like, use your sick time, you'll be all right.
Yeah, that's why this is a message to them.
Yeah.
This is a message to leaders and higher ups in these departments of, if you want to increase retention, because I know you do, because I know it's a problem.
It's a problem. You are right.
And if you want to, provide additional incentives for younger generations coming on to departments who are way more educated and way more insistent that their mental and emotional health be taken seriously.
Absolutely.
And if you want solid, stable responders.
Right. And so the responders are leaving after 5 years now. Right?
Of course
because
they are.
of the horrific things they've seen, where if we can support them mentally, we'll be able to retain them longer too. So recruitment and retention.
It's definitely a win-win to be able to recognize that this profession is going to change people.
Yeah, absolutely.
And that means we need to be flexible about how we help them in that change and let them continue if they want to in their profession, so they can come back.
Right.
It's better to have a flexible return policy than a no return policy.
Absolutely, yeah.
And then I would also recommend, and I know some departments do this and some stations do this, and more often than not, or it varies, but QPR training, question, persuade, refer, that is a free training.
Okay.
And it's more of a truncated training that is all about helping people recognize and address, so even though first responders might be like, I know, like, it's kind of like crisis intervention-y and I know how to deal with this, but it's something that if we make it a part of the culture, can start to help shift that culture okay, so stigma might start to reduce if we recognize, okay, we have our QPR training coming up, and that reminds me, so-and-so has been like MIA recently, more isolated, so it can just help us get back into the framework of like, okay, we got to help each other, and this is how we can do it. Feel more confident about approaching it or being in the presence of someone who's struggling, and not have to shut down yourself because you might also be struggling. It's like, how do you carry someone out if you feel like your legs are broken, right?
Yeah.
So I think I just took on your accent.
It happens sometimes.
And then the other one is mental health first aid.
Okay.
Which, have you heard of mental health first aid
I have
training?
not. I would say I've heard of it. I have not done any looking into it. Or
Gotcha.
anything.
Okay. Yeah. So it's something that is more in depth.
Okay.
And it is, I think, something that as first responders, would be a great training to have yearly with your other annuals, of just remembering and having it's usually a day, give or take, maybe half day, depending on what you sign up for.
Okay.
But mental health first aid is going to give more detail and go into more of the nuance of how do we respond effectively to someone, particularly, addressing things like suicidality and those types of crises where your response is not going to be to just take them to the hospital like you would with the general public. Your response is going to need to be more trauma informed, and the mental health first aid can really help people feel more confident in how, like what we talked about today, of how to be a listener, how to have that conversation, how to ask that question, how to check in with people, how to collaborate. Building those skills is going to be important. I hope everyone watches everything today and gets as much out of it as they can, but it's going to need to be reinforced, right? Otherwise it'll be like, oh, I did that training, or I did that, listen to that video, and I know there's something to do.
Right.
So we need to be incorporating these kinds of trainings, education, again, stigma and lack of education. Those are the things
Right.
that are the biggest barriers.
So one of the things I also took, and I don't know if it would be something for departments, is ProQual, and it like measures your
Yep.
passion fatigue, burnout,
Yep.
secondary trauma, stress. I had to do it for a class that I'm
The
currently
assessment.
taking. The assessment. Even if you do it yourself and just kind of go through that and kind of just see where you are.
I have a copy of that if you want. We can post it with our other links.
Absolutely, yeah. It was very eye opening when I took that. It even measures your moral injury and things like that. So it was a great tool to be like, where am I sitting?
Yep.
Right.
Self-assessment.
Self-assessment.
Not ready to
right.
talk to anybody yet. At least you can get a
Yeah.
thumb on the pulse of like where you're at.
Yeah. So if departments had put that out as like, here's a self-assessment tool for you, right? With the other resources they have, I feel like that would also maybe something to like add in any of that.
We need
right?
to be building an infrastructure that is going to be taking care of people's mental and emotional health. As first responders, it's just inevitable that your experiences on the job are going to change you.
Absolutely.
You know this, but they're going to change you in ways that any human would change.
Yeah.
Experiencing these things. So we need to really recognize that you're humans.
Yeah.
I know you put on the uniforms and you feel like superheroes, and you're amazing people, and also you're still human.
Yeah.
And that means that we want to be able to care for you just the way that you would want to care for everybody else. You need care too.
We do. We absolutely do. So, fantastic. All right. Thank you today. If you have any other questions, please let us know. We will be doing another video soon. We'll let you know what the content will be. Any last words?
No, I appreciate everybody who watches, and I hope that they take something from it. Did you?
I took something from it.
Yeah?
It was, so, I mean, knowing the difference between those passive thoughts and the active, and we don't actually have to go to the hospital, I think that helps.
They're big pieces that
big
can kind
piece
of
that can
make a little space.
Yes, and how to not be like the Homer Simpson and just kind of disappear into the bush when we talk about these things. Like, it's okay to talk about it, and it's not going to push somebody as long as we're talking about it in a active, listening, collaborative way.
Collaborative way.
So I think that was very good. Yeah.
Awesome.
I feel more confident talking to, say, my coworkers about it now, I would say.
Awesome.
Yeah, so
glad to hear it.
Hopefully other people listen and do the same. Yeah.
Thanks, everybody.
So, thank you. Bye.